everybody. I know it's a lot of sitting. Thank you for bearing with me. It is a great reason for it, though. I'm going to pass it off to Dr. Copenhaver. We did introduce you, but feel free to accolade it up.
Absolutely. Well, it's a pleasure. Thank you, guys. And for many of you coming to Sacramento, welcome to Sacramento. We turned up the heat for you outside, so make sure you're comfortable. Welcome. It's always kind of an interest and a mission that we've had for many years to talk about pain as it's associated with cancer. And really, and if you can hear me, please, if it's difficult to hear, I'll certainly, high school drama, I'll go ahead and project. The thought process largely is that, and we'll see some brief data, we've been really successful. You've heard some amazing work with surgery, oncologists, the reality being that we're living longer in general with disease. We're more successful. But one of the difficulties is besides quantity, we're looking at the quality of the life that we have subsequent to all the considerations, whether it be surgery, whether it be chemotherapeutics or radiation, because some of those things really as treatments and therapeutic modalities have injury, right? They cause injury. So we're aware of that. So we're going to try to dive into that and discuss a little bit about that today. Also, completely fluid. If there's questions, please don't hesitate. I know we save them to the end, and maybe it's a burning question. We can certainly answer it, do our best to try to accommodate as we chat, okay? A little bit about me, not to be too much, it's not monopolizing time about me, but I had an interest in cancer-related pain. I'm an anesthesiologist by trade. I focused early on liver transplant physiology and anesthetics for that, but went into cancer-related pain because I was a caregiver. And I realized that there was a limitation in understanding pain as it relates to that experience. And I would tell you today that there still are some limitations. So we'll talk a little bit about that. I'm the vice chair of our department, and I run our pain medicine group here at UC Davis. I really don't feel it's part of any department. I actually feel I'm part of Dr. Randall's department. We're a division of the university, and we've kind of had that very nice kumbaya hippie culture that we're part of the whole university, not just a single department. I do have one disclosure. There's a company called Journavix. We'll talk about it. There's a really new drug. We've had some very interesting work with that line of reasoning and thought process here at Davis. So I'll talk a little bit about that. We're also the location, not to put a lot of salsa in our tacos or a little bit of guacamole, maybe extra, or the location that we published this book. Now, many books, it's kind of interesting. I think everything's online. And I don't know if there's really textbooks really used anymore, but apparently they are because we still publish them. This is our large textbook in pain management, the Nika's text, and we participate here in publishing that text. I kind of believe in telling you kind of like the old adage for the Nielsen rating on CBS, right? Tell them what you're going to tell them, then we'll tell them, and then we'll tell them what you told them. So here's a little bit about what we're just going to talk about. Scope of the problem, looking at cancer prevalence, but really just survivorship and understanding that. We mentioned that. A little bit about the cancer pain assessment. What would we want ideally if someone has or is afflicted with pain in their first touch? Perhaps in a cancer center, what would we want for that assessment to look like? A little bit about pharmacologic management in the setting of giant cell tumor and how that could, what that would look like, but I'll give a little bit more of an expansive understanding about that. And then non-pharmacological therapies. And then lastly, some really kind of cool advancements, really interesting things about pain. And really, when you think about pain, it's really something we all have had an experience. We all share that human condition of what pain is. I think it'd be interesting to let you know that pain was the least studied phenomenon for many years. You probably know there was an opioid crisis. And it was pretty easy to prescribe opioid therapy. But the understanding really about NIH dollars that were allocated for pain research was very minimal. And it's only until recently that we started looking at understanding about pain. Just looking at survivorship in general, we know that there's about 18 million survivors, all comers to different types of malignancy. But what's even more interesting is what's projected in 2040 at over 26 million. And the idea that we're doing well, there's an understanding there. But there's an element, there's kind of an undercurrent kind of the news flash, kind of the thought process that we're victims of our own success. Some cases, we're living longer, but there's a lot of pain associated with what is transpired. And so our idea is trying to think about how we can marry those two. And that philosophy is relatively novel in that sense, because I can't say it's shared everywhere, or explored everywhere, when that's part of the impetus of the conversation. So what about pain? About severe pain, in many different surveys, suggestions, I would tell you that about moderate to severe pain, about 35% of all presentations. And then if there's cancer progression, there's a much greater prevalence, right? But I would tell you also, interestingly, if you look at certain disease states, this outside of the conversation of the type of giant cell tumor, but if you look at thoracotomy syndrome for lung cancer, that's actually very well known to cause persistent pain. That surgery subsequent to removal of that tissue. Breast cancer, about 37% incidence of pain down the arm, intercostal brachial neuralgia, and we see it. And the question now that's kind of we're faced with, why didn't we talk about it a lot more before? Why is it something that seems relatively new? Well, it isn't, but it's largely because we were just, I guess you could say, when you ask patients, they said, my God, Dave, I was grateful. I was grateful for what happened, the surgery, the considerations, but I'm telling you that right now, at this point in my life, 3 or 4 years later, I'm in pretty significant pain, and I have some questions about my therapy, what choices I made, and survivor guilt can enter into this kind of consideration when it's severe. So I think we're at a new era of trying to understand and reconcile those considerations. It's really a holistic approach to cancer care. So a little bit about giant cell tumor, and the idea in the synovial lining is really understanding about inflammation and the immune system and how they're related, but then also this kind of almost like a cloud that occurs with inflammatory processes over nerves, over the surface of the nerve. Because when we think about it, all sensations transmitted through the body, the core to the brain, and it's a neurological impulse. But there's this cloud of neuroinflammatory relationship. We're going to try to bring that into perspective. So just kind of a quick idea, understanding that cancer may be due to a variety of different circumstances, from tumor progressing, actual tumor compression, to changes in blood flow, to alterations in neurologic structure, and that microenvironment. Really, I know it sounds, to this group, it's really not, I don't have to kind of have a used car salesman speech to describe why it's important, but I would tell you that as a pain specialist, it's kind of a humble Birkenstock wearing country pain doctor. I would tell you, oddly, when we're talking with administrators, large hospital systems, I have to advocate for this consideration in many ways. And there really is a lot of understanding of why it's important. We'll dive into that. And really, suffering, loss of control. What I would say is inability to control the scenario around us is really one of the more problematic issues. I didn't need assistance from somebody else. I didn't need their help for this particular consideration. I didn't need a ride. I could drive. I wasn't on these medications before. And all of that can be unsettling and disconcerting as we kind of dive into the ether and profundity of what the experience is. Okay, just changing gears really quickly, because when we think about cancer, pain, and bone, Pat Manzi is a good friend. He's over at the University of Arizona in Tucson. And Pat's interesting because he was an attorney, and then he went into pharmacology. I don't know how that worked out. He's like an expensive attorney or something. And his brother, Phil, they both went into understanding molecular design. And they ended up having a lab at the University of Arizona. I think they grew up in Scottsdale. Anyway, it's always fun to go hang out with them, because they're actually not only just great researchers, but they're delightful people that they like to choose around. Really a wonderful environment. But they involved themselves in a very unique understanding. They took prostate cancer as just an idea, because it's one of these malignancies that metastasizes the bone. And the idea was, why does the bone hurt the setting of cancer? Well, we had some kind of no-brainers, the idea that there could be tumor progression, altering the structure of the bone, expansion perhaps, just that very pressure. We could kind of conceptualize those ideas, but they went into it a little bit further. what they were able to see here was just normal bone. They took some microscopy looking images. Then they went ahead, and I'll show you what the spaghetti is in the middle and at this far right location. By placing normal bone and inoculating the bone with prostate cancer cells, they were actually able to see this sprouting of almost this fishnet stocking neural filaments over the surface of the bone. And what drove that hypersensitivity to bone? Bone's an incredible organ. I mean, I don't have to say anything more than Dr. Randall is an expert in orthopedics. The bone as an organ system is incredible. However, this idea of its sensation, the actual fishnet stocking sensation over the surface of the bone is unique and interesting and novel in many ways, which is time Pat was deciphering this. But this idea that there's a drive and sensitivity to the bone after inoculating the bone with tumor cell. Now, both images above and below look pretty similar. You have normal bone, you have inoculation, and then you have some change. But what occurred here? Well, the top picture is really looking at the first inclination of inoculating tumor cell, then subsequently seeing the neural filaments grow, and then giving a nerve, what we call a nerve growth factor inhibitor. A treatment suggests it can inhibit the sensitivity of the bone in this particular scenario. And interestingly, vast changes over the surface of the bone. Meaning, would there be a strategy to offer individuals an infusion of nerve growth factor inhibitors that are targeted after we find out what type of cancer they have? And would this be useful? Would it add to a chemotherapeutic regimen? Calcium gene-related peptide is another, how can I say, a molecular protein design structure that's upregulated in the setting of pain. Also, that was changed as well. That was noted at the bottom. Very similar after nerve growth factor inhibitor was given. So this interesting interplay of understanding nerve filament growth and its inhibition in the setting of nerve growth factor inhibitor was key. What I would tell you, the punchline with this was a quest to find new drugs that could do this. So we'll keep that on burner number one, slow simmer. The idea of new medications that could considerably help with this phenomenon.
How much time was there between those two?
Approximately, you're looking at about 4 to 6 weeks. The interesting part, the punchline, really was, it wasn't so much the inhibitor inhibiting the tumor causing the drive. What Pat found in his brother Bill was that it wasn't so much the tumor, it was the tumor's relationship and signaling to the immune system. And that the immune system then had a relay to our neurological system over the surface of the bone. So there was an intermediary step that was somehow missed. And it's the relationship of our immune system to cancer, which now has really been exposed, right? There's many biologic therapies, but at this time, also in the setting of pain, is unique and important strategy. When we look at just the assessment of what we would want if we wanted our loved ones cared for when they come in, what would we like the conversation to look like? And just that in and of itself, there's a lot of hand-wringing and perseverating intellectually of what that would look like. But we do know this, we want an understanding because we know in the setting of malignancy that increased anxiety, fear, both amplify existing pain. And in the brain, there's specific locations like the amygdala that fire off to the setting of anxiety, and that can amplify existing. Depression, personal distress, kind of preoccupation with pain. We have many folks that will tell me, Dave, I'm 42, I didn't expect this scenario. I want to say I was diagnosed at 36. I didn't get my life insurance. I have a family. At that time I thought about it, I was thinking, and I've had entire conversations about this and how distressing the scenario is, and that repeat, almost a rumination of this thought at night, not wanting to maybe discuss that with the significant other. And how difficult, just one point of light against the Milky Way galaxy of thought, distress, but important to discuss. And this loss of control, decreased capability of function, nausea, poor appetite, and of course, interrupted sleep, all important and needs to be discussed. Even the spiritual considerations, which are key, because somehow we're agnostic in allopathic Western medicine, but it's important to incorporate a whole person care and looking at this and reevaluation of religious beliefs, altered meaning when this kind of diagnosis happens for patients, decreased sexual function, sometimes altered appearance, even with bony lesions being removed, never mind head and neck cancer, other considerations that are incredibly problematic. So with this psychosocial assessment, I think probably if I had to give the executive summary, there are some key points that are often missed. And it's what is the meaning of pain for the patient? Sometimes if pain resurfaces or is there and it's present, some folks will say, does that mean the cancer is back? Is it getting worse? Or I really would like to know because it really creates a lot of angst. What are my past experiences with pain? Maybe I had a brother, or maybe my son was involved with opioids in a problematic way. Maybe they had a history of abuse. And I desperately want to stay away from opioid therapy because of that. But I didn't know that if I didn't ask. And if we didn't have this type of in-depth conversation. Or, I really would like to know because it really creates a lot of angst. What are my past experiences with pain? Maybe I had a brother, or maybe my son was involved with opioids in a problematic way. Maybe they had a history of abuse. And I desperately want to stay away from opioid therapy because of that. But I didn't know that if I didn't ask. And if we didn't have this type of in-depth conversation. So what do we focus on? We focus on the physical exam. We remind ourselves that we have to do the exam frequently. We talked about diagnostic imaging is key and repeating it because things change a lot. And not to leave it and just address it without frequent evaluations. So we do that in our physical exam. Now, I want to mention just briefly, when we look at giant cell tumor and chemotherapeutics, there isn't vast qualities of chemotherapeutics that are utilized specifically. But what I want to tell you about this is that because it's germane to the discussion, we talked a little bit briefly about chemotherapy-induced peripheral neuropathy. In rare instances, some chemotherapeutics are utilized, right? And we do know that, how many of you have heard of individuals that have burning hands and feet? Have you heard of that? Now, isn't that odd? You get a chemotherapeutic agent, why isn't their earlobes burn off? Or their nostrils? Or eyebrows? I got that eyebrow burn again off the chemotherapy. Why is it the hands and feet? Well, you got to ask these really interesting questions. I find it almost, you're in the setting with like a 10-year-old. They ask these questions. How come the hands and feet? Well, I don't know. Maybe we should figure it out. And this is an interesting group. PainExhibit.com is a group of artists here in Sacramento, and they use art to actually kind of, in a sense, provide some form of respite, therapeutic release for their pain. This was someone's exhibit on chemotherapy-induced neuropathy, of course, not pain for it. Prevalence, if you look at cisplatin, platinum-based drugs, 70 to 100% individuals will have some aspect of chemotherapy-induced neuropathy. The taxanes, paclitaxel, cisplatins are used, for example, in colorectal cancer. Taxanes, for example, microtubule disruptors, those kinds of things are used in some of our breast cancer considerations. Thalidomide used in multiple myeloma. But you can see there's this consideration, and it can occur with a single dose, cumulative doses, and it can be peripheral nerve injury. We know that can occur. We're going to dive into why maybe hands and feet, at least the postulate, the hypothesis for this mystery. Just really briefly, what do these chemotherapeutics do? And then we'll dive into essential details because we're going to talk about giant cell considerations. But chemotherapeutics, the immune system, disrupting mitochondrial DNA, microtubules, we talked about the scaffolding of the cell, meaning disrupting cells' division to reproduce, right? Because in cancer, these cells are reproducing uncontrollably. And altering DNA, for example, in the setting of the planet. I know it's a busy slide, and it looks like something out of SpaceX or NASA, right? But suffice to say, if you have platinum-based drugs, there are several different types of damage, but what I'm really going to direct you to is the idea that there's an atrophy or loss of cells in the dorsal root ganglion. This idea that there's a very good specificity to almost like decreased blood flow, ischemic, anoxic, decreased oxygen to these cells in the dorsal root ganglion. What are those cells? Well, we have our spinal cord, and then just outside the spinal cord are these small onion holes. These what are called dorsal root ganglions. Almost arcane, but very ancient structures as part of our evolution, and then nerves that traverse out of the body, brain, spinal cord, and the dorsal root ganglion. It's in that location that we started to learn a lot about why the hands and feet. We know that when we provide platinum-based drugs, there's a hyperexcitability that takes place and injury specific to those cells. And there's a rich blood flow, almost as if the dorsal root ganglion is wrapped like an enchilada. We're also the location, not to put a lot of salsa in our tacos or a little bit of guacamole, maybe extra, or the location that we published this book. Now, you know, many books, it's kind of interesting. I think everything's online. And I don't know if there's really textbooks really used anymore, but apparently they are, because we still publish them. This is our large textbook in pain management, Janika's text, and we participate here in publishing that text. Okay, what kind of medications, and let's dive into a little bit of this about specific to what we're here for today. Well, we know that in the setting of the synovial lining and the structures around it, that inflammations and steroids can be helpful, but also anti-inflammatories. And the idea of some medications like ibuprofen, Motrin, Movic, Voltaren, all of those drugs block prostaglandins, the molecules that are involved in inflammation, ubiquitous. Now, there are some unique attempts at looking at other drugs, but I would tell you that NSAIDs have had a role. But the inflammation is key. Keep that in mind. Of course, there are several other medications, like steroids. We're going to tend to talk about a couple to 2 or 3 of them on the list. I want to mention that specific to giant cell tumor and in the synovial lining and doing injections into joints, there is an understanding of using, for example, if we scroll down our list here, etanercept or tumor necrosis factor alpha inhibitors. TNF alpha shares this specific domain between neuropathic pain, and inflammation. And this relationship has allowed for some of these types of molecules to be tried and trialed within essentially joint injections of etanercept. But I would tell you that there's still kind of an understanding to try to look at infliximab and etanercept as a strategy. We're going to dive into some things that we do here and then certainly have rich conversation about what we have. Okay, if we think about it, how many of you are familiar with gabapentin? I mean, everybody. I mean, that particular company has done an incredible job. If you can imagine, gabapentin is almost probably offered here next to the water bottle. I would tell you it's like a party. Gabapentin, we know, was an anti-seizure drug that couldn't stop the seizure to save its life, right? It decreases characteristic frequency and firing of electrical firing. It works on calcium channels, particularly in the neurological peripheral system. We find it to work well. However, it went on the unemployment line and it found a role for peripheral nerve considerations, right? Many of the difficulties, though, are it causes a lot of sedation, a lot of cognitive impairment, ankle swelling, and it can even alter mood. Other medications for neuropathic pain that have been used by our American Society of Clinical Oncology are the others, like these antidepressants that are old from the 70s, tricyclic antidepressants, amitriptyline, Elavil, nortriptyline, Pamelil, and topical gels associated with those. And we'll talk about ketamine. But first line was really Cymbalta. Cymbalta is a serotonin norepinephrine reuptake inhibitor. It turns out that when you have pain coming in through the body, in my house, I'll tell you, if I have young kids and if the lights are off, you're walking, just want to go get a glass of water. That's all. They're trying to bother anybody. It's 12 midnight, just trying to do something simple. And you walk and then you step on something and you're like, whoa, it was like a landmine. And you feel a sharp impulse come up through your foot cross over the board to the brain. Well, quickly, there's a reflex on it, you take your foot off, whatever it is, and then simultaneously you turn on the light to investigate. Really, it's all rapid. I see a Lego, a Boba Fett. Boba Fett is attacking. Now, the reality is, with that quick impulse, we call that the spine-brain highway, the spinothalamic tract. Brings information in from the periphery to the brain. Now, before I turn the light on, the brain is amazing. I mean, isn't it amazing? The brain is trying to figure itself out. I mean, all these neurons, it operates on itself. Okay. Oh, we don't have to talk about that. But I would say this, that if you just think about it, before I turn the light on, I'm actually remembering being 12 years old, running across the dock, stepping on a rusting nail, grabbing a rope swing, and flying into a lake. It's trying to process everything that feels like what I just felt in nanoseconds, right? But then quickly when I see it, I realize what it is. There's no harm to me, really. And I take a deep breath. That element of a deep breath and an attenuation in pain or a dampening of pain is how Cymbalta works. Because not the spine-brain highway, but pain is attenuated from the brain spine, the craniospinal tract. It's an ability to dampen incoming pain or decrease the volume. And it runs off high-octane serotonin and norepinephrine. And it has to increase those two neurotransmitters in the right real estate. So Cymbalta has won approval for chemotherapy-induced neuropathy and also had FDA approval not only for neuropathic pain, but musculoskeletal. Was able to encompass that. And it can be utilized as such. And I know what you're thinking, Dave, that's 11 years ago. Well, when we put up the National Cancer Center Network guidelines, Cymbalta still, duloxetine still holds that consideration as a better therapy. But what about just dull, throbbing pain, deep pain? What opioid should I use? We know there's a lot of problematic issues. Opioids have tolerance. They can cause constipation. They cause dependence, meaning I have to use more of them with tolerance than to get the same effect because they have that particular issue. Those are the fentanyl, the hydromorphone or Dilaudid, the Norco, the oxycodone, right? But this idea that also they can cause addiction. Maybe it was unbeknownst to me that I carried that genetic genotype in my body and that predilection. But this idea that this prospective brain disease of what is addiction can be somehow uncovered with opioids. All understood. There's a medication called buprenorphine. How many of you are familiar with buprenorphine? Buprenorphine is in its own class. It's not a full agonist, meaning full gas pedal pushing down on the mu receptor, but it's a partial agonist. Remember that if you give a lot of morphine to anybody, why did it cause so much trouble in the news? Well, it caused so much trouble because people stopped breathing. Not unintentional overdose death, largely due to respiratory failure. However, what I would tell you is buprenorphine has a respiratory ceiling. It has a respiratory ceiling. It actually offers better when you compare it to full agonist cognition, less sedation, less constipation. And there's some opportunities because it comes in many formulations that are key. You could put it in the buccal cheek, under the tongue, and there's even a patch. Now the patch, I have to tell you, won approval for taking care of older adults because it's one patch per week. And one patch per week can be much greater endurance because it's hard to remember to take something several times a day. So buprenorphine can be helpful. And what is it in the setting of cancer-related pain and joint pain and problematic considerations or persistent pain? It can be helpful. And so if we're looking at opioids and we're concerned with it, this could be a pharmacologic strategy as a safer strategy than some of the other full agonists. If you're interested in a paper, I really like Mellor Davis. He's an oncologist over at Geisinger. He's a snappy dresser, okay? And he kind of has these great kind of circular rim glasses. I really like working with Mellor. But he wrote a great paper almost also 13 years ago, 12 reasons for buprenorphine. And I think it's a great one. You can easily Google it and find that information. What about ketamine? How many of you have heard of ketamine and its use in pain? Ketamine isn't new. It's an old drug. It was actually designed in the sixties at the University of Michigan, Dr. Domino. Then it was a workhorse as an anesthetic in Vietnam. However, it has some important points. Why is it useful in pain? Pain tends to persist because of some feedback mechanism, a perpetual feedback loop that seems to persist, particularly with neuropathic pain. It's not like you stub your toe and it gets better. Some of the conditions we're talking about are persistent. Ketamine blocks what's called the N-methyl-D aspartate receptor. That receptor is involved in the perpetuation or feedback loop of pain. So ketamine, whether you're having a major surgery, a joint surgery in the hospital, and you're complementing an opioid regimen in acute pain, ketamine can be helpful. Whether you're using ketamine outpatient to treat neuropathic pain, there are many locations that have designed infusions of ketamine over several days. For example, here at UC Davis, we have a ketamine infusion protocol that was designed in concert with Cleveland Clinic in Stanford. Our protocol is a sub-anesthetic infusion, meaning you're not getting the anesthetic or substantive doses that would provide side effects, and we'll talk briefly about side effects. You're getting a sub-anesthetic dose for a period of time, and that period of time is approximately 4 hours, once a week for 4 weeks. That's how the infusion takes place. Letting the drug sit on the receptor, and then subsequent to that, the intent is that there's less in pain for many days, weeks, subsequent to the infusion. Okay, I know what you're thinking. Ketamine, yeah, it's in the psychedelic class, right? Maybe you see the phencyclidine ring. And I would tell you that in 2019, this drug, it was like Stella got her groove back. Another whole show. It was another sitcom that you would be able to do. Ketamine found itself in this scenario. Ketamine is absorbed. If you take it orally, it converts to norketamine, which is about a third less potent than the parent compound. But norketamine goes through the liver again and becomes hydroxynorketamine. Hydroxynorketamine has no pain-relieving analgesic properties at all. But when given directly, it's a rapid antidepressant. Most antidepressants today take 6 weeks to work. Ketamine, when inspired nasally, can take 72 hours. So it's a rapid antidepressant, and that was what garnered approval just a few years ago. Okay, so when we're thinking about giant cell tumor and we're talking about the knee or other joints, we talked briefly that NSAIDs and steroids can be helpful. We talked about the fact that radiation, we didn't mention it much other than it could cause injury, but the idea that radiation has been utilized. There are also the uses of radioactive tracers to be placed in the joint, for example. But we try to offer therapies that are less injurious, that cause less issue. And so I mention only those because those are there. You'll see that in other types of cancer, from brachytherapy, small seeds with radiation therapy, chemoembolization, really don't apply to what we're discussing really here today. We do have what we call ablative therapies. We're going to show you a few. Those are some that we'll mention in just a moment. And then we're going to dive into neuromodulation. So radiofrequency ablation is not new. It's old. It's the use of heat, but being very specific in how we apply it to specific nerves. In this case, to the nerves that, as we genuflect to the knee, the sensory nerves that give sensation to the knee itself, as well as sensory components of the femoral nerve and the obturator nerve that give innervation to the hip. So we have a process where we do a test block to those genicular nerves under X-ray. Well, why would we do this and when would we do this? Maybe you'd have a patient that says, you know what? Hey, Dave, I really like the idea of buprenorphine, but that's not for me. I'm not interested in taking something seemingly partial agonist opioid, nor do I really want to look at Cymbalta. I heard that it can help musculoskeletal pain. You know, I did try steroids. I tried Celebrex, and I did try anti-inflammatories, but it wasn't enough. I'm really looking at trying to see if there's some other ways I can help with my knee pain at this particular time. We can block the nerves to the knee, and that can be a local anesthetic block. And then subsequently, if there's benefit from that diagnostic local anesthetic block, we can then ablate or burn the small sensory nerves to the. Now, we're careful in using this because repeating ablations over time, there's kind of a diminishing return. But maybe we're at a position where there needs to be a joint replacement and we're not there yet. Or maybe we're just after joint replacement or preceding joint replacement or around the perioperative experience, we could do this to help lessen pain or improve the postoperative course. So there's elements of where it can be utilized very strategically to help people. Similarly, the same process for that femoral and obturator nerve are done for the hip itself. And we call it hip ablation, radio frequency ablation. Now, I know we've talked about it, it's a whirlwind through different strategies, but if you think about medication, specifically selecting the right one, if you think about specific ablative techniques, like in this case for the knee or hip joint, but there's some strategies that are not as injurious as burning things, because cutting and burning and putting chemicals on things we know has limitations. So neuromodulation focuses on the use of placing pacemaker-like devices, electrodes into the spine, to distract the brain from pain by bombarding the spinal cord with unique signals. What's the medicine here, Dave? Well, the medicine is unique software that bombards the cord with unique packets of energy that distract the brain from pain. And we can dive into other considerations of that, but the proprietary industry kind of considerations for each device is really in the software. So the device itself hasn't changed dramatically. Now, dorsal column is actually placing electrodes into the epidural space, the space that's above the spinal cord. We know the spinal cord is surrounded by 3 plastic bags, for lack of a better term. Saran wrap, the PIA. We have an arachnoid layer that looks like spider webs, and then a dura, which was Latin for tough. And it surrounds the whole cord in fluid. And to confuse matters more, epi was Greek to say above the dura. And we place these electrodes above the dura. And if we put them in specific locations, we can distract the brain from knee pain or foot pain specifically. Now notice they're in the middle of the spine. They're now MRI compatible. I'll tell you many years ago they were not. There's various different types of understanding. High frequency stimulation, bombarding the cord with over 10,000 kilohertz of stimulation. The patient doesn't even feel any sensation, they just don't feel it. So very unique. 10,000 kilohertz was patented by one company in Redwood City. So there are other companies that try to model that with just slightly less stimulation, but there's various different types. There are also, this is that dorsal root ganglion that I mentioned earlier, this little onion ball. Here's the central cord. There are devices that go right over. Now imagine I just have right foot pain or right knee. This can be placed over the dorsal root ganglion specifically of that location. It's not a drug. It's not an ablative procedure. The device can be placed in trial where you can try it out and see if it's helpful, and then determine if you are a candidate for a full implant that's like a pacemaker device. That's implanted under the skin. You can understand that it can cover the foot. There's less migration of the electrode because of this type of technique, but suffice to say, it's also MRI conditional. Oh, interestingly, it's hot off the press. These devices are being utilized for chemotherapy just now. Okay. Yeah, Dave, you told me a lot about these stimulators and things. They're kind of unsightly. I don't know. That seems a little bit much, but maybe not in the spine. What else would you have for? Well, the idea that there are new peripheral nerve stimulation devices, maybe after a hardware placement and there's persistent pain. You can actually use small electrodes over the peripheral. And this technique is, I would tell you, a versioning new strategy to assist folks. However, many of these peripheral nerve stimulators aren't conditional or compatible with MRI. And so we're at this kind of consideration. But they may be helpful in certain segues between surgery, rehabilitation, many considerations that might be for short periods of time. Okay, let me take a pause here for a moment. Those are all the neuromodulatory techniques there that we talked about. How many of you have heard of intrathecal pumps or pain pumps? Okay, these are in very severe circumstances trying to address severe pain. We can utilize medications directly delivered to the cerebrospinal fluid in the spine. Probably all can imagine that, 10 milligrams of oxycodone is approximately, you're looking at, it's a little bit about 1.5 times more potent than morphine. So if you look at 15, it's about 15 milligrams of morphine. So if you think about morphine in general, it's a good drug. It'd be a terrible world without it. But 1 milligram of morphine in the cerebrospinal fluid is equal to about 300 milligrams. Very potent space. There's many different unique medications that can be given in the cerebrospinal fluid specific for pain. And when it's severe, it can be a modality use. So intrathecal therapy has many different forms of evidence. Lisa Stearns was a great colleague of mine. She passed away a few years ago. She wrote a great paper because many of us use intrathecal therapy for severe cancer pain, but the argument was it's too costly. And we would be shocked because we're like, well, what's the cost of that quality of life for that individual for 6 months, a year, or 2 years? How do we make that ethical decision? But she was able to demonstrate how efficacious it was. Basically, there's a device, a reservoir that's implanted in the abdomen, and a catheter that's placed in the spine. That catheter can deliver any host of the platform of medications directly to the cerebrospinal fluid. From local anesthetics to opioid to even very unique conotoxins. There's a conotoxin from a snail, and that drug is an N-as-in-Nancy type calcium channel blocker, only specific for neuropathic pain that can be placed in the spine. Okay, if that's not enough, folks, we're going to try to think about some novel kind of new emerging strategies, and we could talk a little bit about what's on the horizon. What's interesting for pain and how it has implications for all considerations for pain, even in the case of joint pain. So racinoferatoxin, you may not have heard of it. It comes from this cactus euphorbia, racinoferate. This particular drug is about 1,000 times more potent than capsaicin. Capsaicin's in hot chilies. And capsaicin can bind to a specific receptor, a linoid receptor in our body that directs pain from neuropathic impulses. When racinoferatoxin is delivered in the cerebral spinal fluid, it's specific to the dorsal root ganglion, where those nerve fibers for pain live. And it's been successful in many preliminary trials. So intrathecal delivery of racinoferatoxin is on the horizon. This was incredibly interesting in the world of bone pain. It came out in anesthesiology several years ago. The work on it has continued to be done. This was single shot injections into the spine with a drug called substance P support. It binds to a particular receptor again on the dorsal horn and dorsal root ganglion, where all those pain sensing fibers are. It binds and destroys the receptor. It's like a drone attack. Very unique and was found to really help a lot of our dogs that have bone pain. Cancer of the bone in canines develops at about 4 times the rate of humans. And when you assess it, they have weighted plates because they can determine what they don't want to put weight on the limb. And you can make that assessment. You may not be aware, but our vet school here at UC Davis is world class and sits at top 1 or 2 in the world as a vet school. So we've worked with them for many years to make that assessment. Okay. I'm going to ask a question of how many of you have heard about the scenario of someone who has, we've been in a remind me about time. I don't know where I am.
There's
Okay.
no such thing.
Oh, got it. Well, I'll tell you this. The idea that individuals are born and they never can see, or someone is born bright blind, or deafness, or lack of smell. little different. You kind of know with COVID that kind of people want, or anosmia, or inability to taste. Isn't that horrible? I mean, you have a genetic disorder where you never could taste something. But what about the inability of never to feel pain? The congenital insensitivity to pain. That, although very esoteric and not common, was deciphered a few years ago and has led to several breakthroughs, which is kind of the breakthroughs of this last January and even the Nobel Prize in December. So I'm going to mention a few moments about this. So Jim Cox, in the late 90s, we discovered the Human Genome Project, right? And it was a project to map out all the genes. We had an idea of all these genes, but we didn't know what they did, what they coded for. SCN9A coded for a specific channel, a sodium channel in the body. Sodium channels are important to translate ions to develop an action potential of electrical activity for an nerve. They found a case of a young street performer, and they're from the UK. A group from England was in Pakistan and saw a street performer that they're like, oh, that's incredible. Look at him. He's walking on hot coals again. Right? And there he goes. And then, of course, doing feats of injury that would be no one else could, must be magic. Right? They're looking at him, couldn't believe it. Well, the reality was he couldn't feel pain. And they asked him further, what about your father? He passed away. Why? He injured himself, didn't know to go to the hospital, developed infection of his eye. What about any other thing? Yes, my uncle, his brother, same thing. Interesting. Started diving into it further, and they started relating this story to our genetic information, right? We realized that none of them knew what pain felt like. What an interesting scenario. And pain serves our inherent alarm system. Injuries to the tongue, bruises, cuts, fractures, infection to bone after fracture. And neurologic exams on site, really there was no changes, really no abnormalities. That there was this really important mutation. And guess what? This comes up as a theme again. It seems as though this particular gene codes for a sodium channel located in the dorsal root ganglion. A location, that onion bulb that takes in sensory information from the periphery, and that protagonist in display keeps coming up again and again. So if you have normal sodium, 1.7 was the channel, you had normal function. If you had increased activity in that sodium 1.7 channel, you had pain, guess where? In the hands and feet. Another version of it, slightly twist on this, you had pain in the eye or the orbit, the mandible, and the rectum. You know that these folks that had paroxysmal extreme pain disorder, they were cast out as suggesting that unvalidated pain seems odd, we don't know, we're going to send you to psychology. We have congenital insensitivity to pain is the absence of pain. So here at UC Davis, we have a lab that focused on molecules binding to that same sodium channel, but it was from a tarantula toxin from our vet school. We've been very successful in finding a new drug and a new molecule. And there are other strategies, actually. Suzetrigine is the newest drug produced by a lab in Boston, Vertex, and this just came to market February. It's a sodium 1.7 channel blocker, and it's used for acute pain, acute pain with moderate to severe discoloration. Non-opioid, it blocks that sodium channel for that effect. Now, you might be wondering what this is. I would tell you, it sounds odd. I'll leave you with this in this scenario that when we're trying to understand pain and our existential crisis, there's been an understanding that psychedelics have been helpful. And they've been helpful in certain ways at helping us bring meaning. You know, sometimes when there's severe pain and maybe we're at a point where it's end of life, or maybe it's in a consideration where there's substantive human hurt. There can be considerations where individuals feel, I have a certain amount of anxiety about all things concerning my disease state, my life, what's going to happen, that I'm unable to find alignment. And I'm so anxious I can't sleep. I haven't slept in 4 days. And the inability to sleep is actually a big amplifier itself. So as humble clinicians, what have we looked at to try to help folks? Well, there's an understanding that in psychedelic research, we now have a psychedelic institute, not just at Berkeley, but here at Davis. And that psychedelic institute has looked at psilocybin, which is part of the Amanita mushroom, and understanding what's that spiritual component of the mushroom, what it actually does physiologically to allow us to align ourselves and to reduce existential angst, particularly at moments that you need it most. Now, DMT is a chemical version of that that can be rapidly given IV and give a brief experience, and the thought process is, could this be used in the hospital as a protocol for folks that have that problem? So I mentioned it as a New Horizon strategy. Okay, I think that's it. Hope I'm not terribly.
Perfect. Thank you, everyone. Thank you, Dr. Copenhaver.